It's my pleasure to introduce our two presenters up here. We have Linda Anastasia and Carla Duff. Linda is a nurse practitioner at the Children's Hospital of Philadelphia. She is also a member of the IDF Nurse Advisory Committee.
There you go, babe.
What are they doing back there?
It's okay. No, just keep going.
Carla is currently the Assistant Program Director for Clinical Research in the Department of Pediatrics and Division of Allergy, Immunology, and Rheumatology at the University of South Florida and is a member of the IDF Nursing Advisory Committee. So, give these ladies a hand, and then I am going to introduce the rest of our Nurse Advisory Committee who's in here helping us, and I'm going to make you stand up and do the princess wave.
Remember, elbow, elbow, wrist, wrist, wrist.
There we go. Don't forget it. Okay, so we have Dr. Beth Younger from Johns Hopkins University. There she is. Thank you. We have Kristen Upland from Midwest Immunology. There she is. From Minnesota. We have Mary Hintermeyer from Children's in Wisconsin. And we have Linda Lentini all the way from Arizona. 1, 2, 3, 4, 5, 6. So I got you all. Okay. And now I'm going to turn this over to the experts. And when they're done presenting, then we'll, if you're going to stay in the room, we'll divide you into tables here and you'll kind of make a line. And they're going to keep it moving. So if you need to talk to them more afterwards, they're not going anywhere.
Oh, we might.
I'm not letting them go anywhere.
When does the bar open? Hi, everybody. So my name is Carla Duff, and I'm a nurse practitioner at University of South Florida. So we kind of changed up our presentation a little bit. This is our disclosure slide. But we changed it up a little bit because there have been some IG talks already. You had like how to choose your IG and some other discussions. So we really focused this talk on how to get the best out of your treatment. What do you do when something's going wrong? So we're going to give a quick overview and then we're going to get into the specifics of what to do when something's going wrong. So what is immunoglobulin therapy? Is there anybody in the room that doesn't know what immunoglobulin therapy is? Yay, that makes it easy. So it's an antibody concentrated from large amounts of donors of human plasma. So they take, people come, they donate their plasma, it gets filtered out and it becomes your IVIG or your sub-Q IG. So if you know anyone who is a plasma donor, you need to thank them because that's the reason you're getting your therapy. Somebody's going and donating their plasma for you. So we're giving you the antibodies that your body's not making. So a lot of times you think I'm getting sick because I can't fight off this infection. So we give you someone else's antibodies so that you can start fighting those infections. So this is the history of immunoglobulin replacement. And I just like for people to see where we started and where we are now. So we started, back in 1944. And for me personally, I always think it's interesting that somewhere in the middle we tried sub-Q, didn't really like it, and then we've come back to where sub-Q is a big thing again. So this is just the history of immunoglobulin replacement therapy, where we started when we used to do IM. Is there anybody in the room that used to get IM immunoglobulin? It's very painful. It was very painful. I have a patient who used to get it IM, and he still has the knots in his legs from the IM immunoglobulin. So we started with IM, had IV, and now we have subcutaneous. And we have a lot of products. We are very blessed in this country because we have a multitude of products, so we can find the product that works best for each patient. In other countries, they have one. Some countries, they have none. I have a girlfriend that lives in a country that has one product, and it makes her deathly sick, but she can't do anything about it. So we are very blessed in this country that we have options. But I'd just like you to see where we are in the chain and what's to come. So you have a choice if you have an immune deficiency. You can either have IVIG or subcutaneous IG. And your choice doesn't have to be forever. If you choose IVIG because that's the best for your lifestyle now, and in 5 years your lifestyle changes, you can absolutely change to subcutaneous or vice versa. But you do have a choice, and you should have that discussion with your provider. If your provider's only giving you one option, you might want to ask why you're not talking about both. So how would you pick? How do you know which route works best for you? That's a choice you need to make. It's a discussion you need to have with your provider. Are you a hard IV stick? Do you take 4, 5, 8 sticks? If so, you might want to think that subcutaneous is a better route for you. Do you not like going to an infusion center? Do you want to be able to do your infusions on your own schedule in your own home on your own time? Then subcutaneous might be a better option for you. If you think, nope, I don't want to be responsible for my infusion, I want a nurse to come, put my IV in, and I want to sleep for the next 4 hours, then IV might be the option for you. But you do have a choice, and that's what's important, is that you as the patient with an immune deficiency have a choice. Have a discussion with your provider, pick the option that works best for you, and then let's come up with the best plan so that you don't have problems, that you're not having constant, your IVs blowing and you're getting multiple sticks, that your sites aren't leaking. Let's figure out the way to make your treatment work the best for you. This was you, right? So now Linda is going to go through the, oh, I lied. I'm doing IV. She's doing sub-Q.
We're good.
I need a nap. My friends made me stay out too late last night. So IVIG, what are some pros of IVIG? Usually it's once a month dosing. Some patients have to get more frequent dosing of IV. Just hush over there. Some patients have to have more frequent dosing of IV, but typically it's once a month. It can be every 2, every 3 weeks. And patients get a quick boost. Their tank is very empty. We give your IVIG, your tank fills really quickly. You feel better. You're like, oh, I felt like crud this morning, but you got your infusion on Thursday, and on Sunday you're feeling good. We can give you a lot of dose at once. So you don't have to do as many frequent doses because we give you a big dose one time. But the cons from that are you often have to take the time off from work and school because you're having to go to an infusion center or a nurse has to come to your home, which means you're having to work on someone else's schedule. And when you have to work on someone else's schedule, there's a good chance you're missing a day of work or your kids are missing a day of school. You can have a lot of infusion-related reactions, headaches, nausea, vomiting, feeling like you've been hit by a Mack truck. And it has the wear-off effect. So, your tank's empty, we give you your infusion, and you feel fabulous. But as the week's going on, and you get to where your next infusion's due, you're tired. And I have patients who tell me, I know my next infusion's due without looking at the calendar because I'm tired, I don't feel good, I feel like I'm getting sick. So then we give you your infusion again, and you feel fabulous. But as the month goes on, you start feeling tired again. So it's a roller coaster. And that is one of the downsides with IVIG. So this is a very old slide that I actually stole from my boss probably 20 years ago. He's not here, so I'm not giving him credit. But no, seriously, I did. I borrowed this from Dr. Sleesman. But I love this slide because it's a good slide to talk about what do you do when you're having a side effect from your IVIG? Because they happen. What do we need to do? Is it a mild side effect? Can we give you some Tylenol before the infusion and the side effect's going to stop? Is it a significant side effect? Do we need to think about, do we need to give you pre-medications and post-medications? Do you need IV fluids? Do we need to slow down your rate? And then the last option, do we need to change your product? But this is a good algorithm to work through because sometimes people have side effects and their first instinct is, it's the medicine. It's the medicine and I need to change my medicine. It's not always the medicine. Sometimes it's things like the rate. We're giving it to you too fast and your body just can't process it that fast. Sometimes it's you get a headache, but if we gave you Tylenol before your infusion, you wouldn't have a headache. Sometimes it's you didn't drink enough and you're really dehydrated. Well, maybe we need to give you some fluids. There are options, but we have to look at what is the problem, how can we fix that problem? And then if we know this is always your problem, say you always get a headache with your infusions, what can we do to help you not get one? And that's what we're going to talk about today when we meet with the tables and we have you all come is what is your issue and how can we fix it? And we may not be able to give you a solution. Our answer may be go back and talk to your provider. But hopefully we can give you some ideas because between the 6 of us, we have a lot of years of experience. I'm not doing that math, but it's a lot. But that is what we want you to think about is there are options to treat your side effects And the options should not always be change the medicine. So these are some tips, which I was just telling you. Pre-medications, post-medications, go at a slower rate. One of the things is increase the time interval. So you know how when you get your IVIG, you start at this dose, and then in 15 minutes we increase the dose, and then we increase the dose again till you get to your maximum dose? Well, maybe we need to lengthen that time, and instead of changing your infusion rate every 15 minutes, maybe we need to do it every half an hour. And you may never get to the maximum dose. You may never reach that maximum rate. Your body may just not tolerate that. And that's okay, because we're individualizing your infusion for you. So your infusion may be completely different from the person in the chair next to you, but that's how it's supposed to be, because we are all different, so our infusions should all be different. And then hydration is key. Alcohol does not count as hydration. I tell this to my college-age students all the time. No, beer is not hydration. Even caffeine is not hydration. People think, well, I had a Diet Pepsi on the way here. Caffeine actually dehydrates you. Water is fabulous. Gatorade, Powerade, but it's really important that you have a lot, that you start hydrating. And if your infusion's at 10 a.m. and you don't start hydrating till 8 a.m., you didn't really help yourself. So start drinking water the day before, getting yourself really hydrated. And if for some reason you can't get hydrated enough, then maybe we need to give you an IV bolus. And then last but not least, do we need to change your product? So now I'm going to hand it over to Linda. For real.
So now we have subcutaneous. This is a wonderful product, and some people actually find this as life-changing. So the pros and cons: it is convenient, it's easy, you do it when you want to do it, you do it in your own home, you can do it in a hotel, you can do it in a friend's house if you want. There is no venous access, so if you're a person that does not have good veins, this is perfect for you. And the one really big thing that is the benefit to sub-Q is that it's a slow absorption, so instead of getting that charge right away into your vein, which is causing the side effects, it's slow, it's into your skin, the absorption is slower, so there is a lesser chance of any kind of those systemic reactions. The cons is that it requires frequent dosing because we're giving it at more frequent intervals. So what we do is we take your monthly dose and we cut it into smaller doses, and then depending on how many times you want to give it is how many needle sticks you're going to get, and depending on your dose, how many needle sticks. So people don't like that sometimes. And then to self-infuse, you have to be able to self-infuse. So if you've got arthritis, problems with your hands, you may not be able to negotiate. If you're a kid, you can't do it. Sometimes you just don't want to do it. But those are the negative pieces to it. So one of the important things that we want to talk to you about is assessing site reactions. There's not really a good, strong chance of you having systemic reactions. The most common reactions that were in any of the clinical studies were site reactions. And often this has got to do with the amount of fluid that you're putting into each site and the size of your needle and the location of your needle. So if you're having site reactions, we may suggest that you increase your number of injection sites so that you are lessening the volume that you're putting in. If the infusion site is too close to a muscle, it's going to hurt. Or if it's too close to the top of the skin, it's going to sting. So needle size is really key here. And that's something that you have to, it's kind of a trial and error kind of thing. So you may try one size needle and find that that's too long or too short for you. I had a woman that I spoke to one time, and she had terrible burning. And so we talked about the size of her needle, and she was using a 4-millimeter needle, which is the smallest needle. That's the needle you use for infants. So the burning was terrible. So the site reactions are usually due to those kinds of things. Also, rotating sites is also important. So if you're starting to get nodules and you're uncomfortable, you need to make sure you rotate your sites and all your sites are 2 inches apart. And there are lots of places that you can give your subcutaneous. You can use your abdomen, you can use your legs, but let me caution you, if you're going to use your legs, don't use the top of your legs, use the side of your legs. Your muscle is right there on the top, and that may be painful. You can use the back of your arm, you can use back here. It beats the heck out of me how people do it, but they do it. So there's lots of, wherever you can pinch an inch.
Yep, your love handles.
So We all have them. So one of the most common causes, like I mentioned before, is mechanical. It is your ancillary supplies. So if you're having any problems, what you need to do is look at your ancillary supplies. If you're using the wrong size needle, if you're using the wrong kind of skin preparation, if you're using tape that you're allergic to, if you're using a dressing that you can't handle, then you need to talk to your home care company or specialty care pharmacy and help them get the right stuff for you. If it's not this, then you need to look at some other things. So is it the volume that you're infusing? Is it your flow rate? Now, your flow rate for subcutaneous is determined by the size of your tubing. So I had a patient who, he was a little boy, and his infusion was going over 6 hours for subcutaneous. That's pathetic. And the poor little thing would cry. And when I found this out, I said to his parents, that's not right. And they didn't know because their home care company didn't know. So we quickly educated them, and now the infusion is 1.5 hours, and he's a happy camper. So, 6 hours is crazy. 6 hours, pathetic. So, these are just some troubleshooting of your subcutaneous site reactions. I think that we'll talk more about this when we get to the individual tables, but I can't read the slide. Who can read the slide? But it is the most common things that happen are it's uncomfortable, and that's because, as I mentioned before, the needle is too short or the needle is too long, hitting your muscle or not getting into your subcutaneous tissue. If your needle is leaking, it's because it's not being taped properly or because it is the wrong size needle. One of the things you might want to look at is also the kind of needle that you're using. There are 2 kinds of needles available. One is a metal catheter, a metal needle that you stick in and the needle stays in. The other is a catheter where you insert it with a stylet, then you remove the stylet and just the little plastic catheter stays in. So whatever works best for you is fine. Just make sure you tape the catheter in really, really well. If there's extreme discomfort with a needle, again, that's the wrong size needle. Another really common side effect is the skin irritation, and often that is because you are not dry priming the needle. Do you all know what that means that you use Hizentra? So when you are priming the tubing for your Hizentra, you want to stop the fluid before it gets to the end of the needle, because if it drips out the end of the needle, that little bit of fluid on the end as it's going through your top layer of skin is going to irritate your skin. So what the recommendation is that you prime the tubing and you stop before it gets to the junction where the needle begins. Long infusion time, that's the wrong size tubing. I mentioned that before. What? Their tables. Okay. So, so instead of asking us questions directly, we're all going to go to our tables. If you want to write your questions down, you want to meet us at your tables, we will try to address all of your questions individually.
And one thing is, I know there are some people who've asked us a lot of questions about push this weekend for subcutaneous infusions. There are those of us who do have patients who do subcutaneous push. So if you had a question related to that, we are happy to answer those as well. I'm sorry? When you don't use a pump. So you use a butterfly needle and you do a smaller volume much more frequently, but it's off-label. None of the subcutaneous products currently approved are approved by the FDA to be given via push. None. But yet there are a lot of patients who do subcutaneous push, and it's very common, especially in other countries. So if you are one of those people, or you've approached me, I've had several people approach me this weekend about it, and you have a question, we will be happy to answer those for you. And then Linda and I are going to come to a table over here. So the other 4 will be here, so we'll have 6 tables in a row. If you would like to disperse to a table, please.